In Module 2, we will review the pathogenesis, pathophysiology, and pathological features of BPD. By the end of this module, the learner will understand the pathogenesis and pathophysiology of BPD and will be able to describe the pathologic features of the old and the new BPD. To help understand BPD pathophysiology, let's first review how the lung normally develops. Based on histological appearance, human lung development is classically divided into 5 overlapping stages, from embryonic state to alveolar state. In human, alveolization begins at around 36 weeks of gestation and continues during the first few years of childhood. Lung maturation continues after term birth, and in addition to thinning of the alveolar septa, the lungs undergo a phase of microvasculature maturation with remodeling of pulmonary vasculature and a fusion of the capillary bilayer. Although the distinctive histologic and structural changes in each stage of lung development have been well described, the regulatory mechanisms that are responsible for these changes are not fully understood. Presently, the pathophysiology of BPD in the very preterm infants is thought to be the simultaneous clash of the programs for lung development, lung injury, and lung repair over the weeks to months after birth required to care for these infants. Therefore, despite similar clinical manifestations, the pathophysiology of different BPD patients may be different, depending on the timing and combination of exposures. The pathogenesis of BPD is highly multifactorial in nature, with a wide variety of factors influencing lung development, lung injury, and repair process. This includes prenatal factors such as prenatal infection, inflammation, fetal growth restriction, and genetic predisposition, and a series of postnatal injury factors that lead to oxidative stress, free radical damage, altered growth factor signaling, and extracellular matrix remodeling. As a result, there is a delay or arrest in the development of both alveoli and the lung vasculature, altered pulmonary repair capacity, and impaired pulmonary immune function. In the pre-surfactant era, BPD was mainly seen in preterm infants born over 30 weeks gestation who received prolonged mechanical ventilation with high pressures and inspired oxygen. Many of these infants died of severe respiratory failure following mechanical ventilation of severe RDS, as described in the Northway series of classic or old BPD. In the upper left corner, a chest radiograph demonstrates the finding commonly seen in patients with old BPD, as described in the blue box. Advances in neonatal care, such as the introduction of antenatal steroids and surfactant replacement therapy, have resulted in the survival of smaller and more premature infants. As a result, the concept of new BPD emerged. Many infants start with minimal or mild RDS that only required low levels of respiratory support after birth. They then have deterioration in lung function and need higher respiratory support and inspired oxygen. However, with proper management, most of these infants will demonstrate slow but steady improvement in their lung function, and after a variable period of time, they can be weaned off respiratory and oxygen support. In the upper left corner, a chest radiograph demonstrates the finding commonly seen in patients with new BPD, described in the blue box. Take a moment to compare this X-ray to the one shown on the previous slide. The pathology findings in infants with the old BPD are characterized by severe lung injury involving the lung parenchyma, airways, and the pulmonary vasculature. Findings include pulmonary fibrosis and hyperinflation, as seen in this histology slide, cystic changes, necrotizing bronchiolitis, peribronchial smooth muscle hypertrophy, severe large airway injury, and pulmonary arterial smooth muscle proliferation. In contrast, The hallmark pathologic features of the new BPD are those with delayed lung development, but mild lung injury. Characteristic findings include alveolar simplification, less and dysmorphic pulmonary vessels, and more uniform and milder regions of lung injury. The two histology pictures in this slide were taken under the same magnification. As compared to the aged match control on the top, the BPD patient has significantly less numbers of alveoli, which translates into decreased surface area for gas exchange. Almost all NICUs will see a few babies each year with extremely severe BPD. It occurs in about 14% of infants with a diagnosis of BPD, which is about 2,500 cases per year in the U.S. The majority of these severe cases occur in extremely low birth weight infants born at less than 1,000 grams. The incidence can be as high as 36% in regional referral centers. These infants are often sick from the get-go, continue to have chronic respiratory insufficiency for months, and many will have acute episodes of severe cardiopulmonary failure from severe lung disease and/or BPD-associated pulmonary hypertension. When looking at the lungs of these extremely premature infants with very severe BPD, the pathological features are a combination of the characteristics seen in the old and new BPD. Typically, they have features of both severe delayed lung development as well as severe injury. This concludes Module 2. Thank you for your attention.
We would like to acknowledge the American Academy of Pediatrics, the Organization of Neonatology Training Program Directors, Neo Reviews, and Abbott Nutrition for their support of this educational program. This concludes this module.